So we're here with Dr. John Katz from San Francisco, Dr. Demachki and I. We just had neurology, neurosurgery grand rounds, so you may be watching this little intro before you listen to his grand rounds and watch it, or after. But there were a number of themes in that. One is a very deep dive in phenotypes of neuropathy with IgM, but the other is just how neurologists make decisions and what are the areas of what arises to a sufficient area of evidence for us to make a decision that makes sense for that patient. So I thought it was a talk that covered a lot of different areas. Dr. Demachki, I don't know if you had any particular question or comment you wanted to make for this little introductory blurb.
Definitely. I want to thank John for an excellent grand round presentation on this topic and also on how we think as physicians. I guess I want to ask John, when was the last time that you would have treated a patient who presented to you with neuropathy and IgM gammopathy and may have had these MAG antibodies? And what did you treat them with, and what did you observe? How long ago has it been the last time that you treated one?
You're presuming he's treated one. Okay, what's the answer, Dr. Katz?
Yeah, so despite what the talk says, I treat these patients all the time. And the reason is that there's a big part of the decision-making that's in the hands of the patients, and I just present the literature to the patients. And I think a good way to get about it is you give one trial of therapy so they'll know what their outcome is. You're not in an area of uncertainty. And then once they know what their response is, they have a much better ability to make a decision the next time around. So I've treated a couple of patients in the last 6 months. Probably there's 3 or so more patients that I haven't treated that I've seen in the last 6 months. But once you present the overall evidence to people, they make different decisions, not surprisingly, about therapy.
So
and
you treat about half at the end of the day?
Yeah, and I have actually never seen a great response, but the jury is still out on these two as to whether they respond. I have seen patients say that their sensory symptoms are better, but I haven't seen anybody really feel like continuing therapy when their antibodies come back is something they strongly want to do.
So finally, you talked a lot about how neuromuscular experts are communicating on the RNMF network. Do you think that has a role in how we make our decisions on a case-by-case basis in dealing with our patients?
Well, I think we're in RNMF 1.0 right now. I mean, something that is worth thinking about is how to make group decisions on RNMF and how to reflect back a little bit on what the differences are and try to come to resolution. I mean, even if RNMF serves the purpose of bringing up what the differences are, maybe at the level of conferences or at the level of talks, we can kind of zero in on what the differences are and what the literature says. So I think it's right now an excellent tool, and as we go forward, I think we'll understand a lot more about how to take these areas which don't have 0.05 p-values and figure out what the right thing to do is.
All right, well, thanks again for a great grand rounds.
Well, thanks for having me. It's always great coming to Kansas. Giants play the Chiefs this weekend, and I'm looking forward to not being overly embarrassed as a Giants fan. So Rick asked me this morning to explain what I'm talking about, and it's not easy because I'm tying about 10 different ideas together in this talk, but I think the basic sum of it, and the reason one of the possible titles is a deep dive into the workup of neuropathy, is because I'm going to be looking really closely at just one disease, which is a neuropathy associated with IgM paraproteins in the blood. And then going from that into questions about how to treat it and why people disagree and what people might be thinking when they look at these sorts of cases. Because with a lot of neuropathy diseases, whether you're in the field or not, or whether you're in a different area of neurology, you probably have a pretty good idea that different people do different things differently. And I'm really, for myself, in very early stages in trying to look at that question. Why does everybody do things differently when they're looking at exactly the same information and when they're looking at exactly the same historical experience, the same papers. I don't have an answer, so I'm just forming preliminary conclusions. If I get this done early, I'd be interested in what everybody else says. So again, when Rick asked me this morning what I'm talking about, it's hard to give him an exact description, so I came up with a few titles possibly for the talk besides this one. One might be an introduction to non-evidence-based medicine. Another might be when you're in the trenches, nothing makes any sense. And by this I mean when you're actually taking care of the patients and at the bedside and sitting in a room with the patient and you're trying to synthesize all this information. You know, we're taught to be white tower doctors or people who are supposed to be really good at what we do. Patients are coming from all over the place to see us. We have great reputations. Then you actually have to sit there and act like you know what you're talking about. And when you synthesize the information, it gets very, very hard. And then the other title might be Let's Just Agree to Disagree, which is something my mom said to me for 25 or 30 years. So first, a bit of background. So just the first 10 or 15 slides or so are really so everybody can get oriented to what I'm subsequently going to talk about, because I don't think it's easy to understand the topic of and the disagreement that occurs unless you have a basic understanding. So for the residents and for the medical students that might be in the room, try to focus a little bit for the next 10 or so slides. So in neurology, in neuromuscular disease, in the field of neuropathy, there's basically a debate going on over which part of the testing when you work up a patient you should pay attention to. Do you look at the lab studies? Do you look at the nerve conduction studies? Do you look at the clinical exam? And I think there's a healthy percentage of doctors who make the argument the exam is telling you everything. And Rick Barron, if you had trained with him in 1993 like I did, you would have been taught that the exam is telling you everything and the subsequent testing is not really telling you that much. There's doctors out there who rely more on the electrodiagnostic studies, and there's doctors that rely more on the lab tests. But when you're talking about the exam, when we talk about this disease, CIDP, chronic inflammatory demyelinating polyneuropathy, one of the observations we've made in the past is that patients who get weak all over their bodies, so the left picture has the gray in all of the muscles, arms, legs, neck, face. People have generalized weakness and this pattern of sensory loss that tends to be large fiber distal sensory loss. They lose the reflexes. Pretty much no matter what, if they have chronic progressive disease, 6 months since onset, a year since onset, this clinical pattern is going to respond to therapy pretty much no matter what your subsequent laboratory testing shows. Is that black and white? No, but it's a good rule of thumb. There's another disease out there which is called multifocal acquired demyelinating sensory and motor neuropathy, or just to make it simply, an asymmetric sensory motor neuropathy, where patients will get more weakness in one nerve territory than the other. It tends to be distal, tends to affect the hands. So this is another clinical phenotype that you hear about or read about if you're in the neurology literature. It looks like a mononeuritis multiplex. Patients who have a lot of demyelination in this clinical pattern can also respond to therapy. And then finally, we have the neuropathy that everybody knows about. The primary care doctors know about it. The neurologists who don't do neuromuscular know about it. It's patients who come in with numb feet. And as a general rule of thumb, if your patient comes in with numb feet, you're at the bedside, it's the first thing you hear. It's a pretty decent chance that you're going to be having a conversation with that patient in the long run that says, your feet are numb, we may or may not have found the cause, and there's probably not a heck of a lot we could do about it. So that's the phenotype by itself. Now, if you come in with that numb feet, people have done all sorts of testing, epidemiological studies, whatever, to figure out what the cause of it is. And there's some pretty good hints that impaired glucose tolerance might be important. There's been other papers in the past. But again, for the most part, what I said earlier is going to end up being true. There's not going to be a lot you can do about it. I mean, even if you show their glucose tolerance is impaired and they're, quote unquote, a little bit diabetic, you're going to tell them to be healthier, really, at the end of the day. And you're going to say if you get in better shape, your neuropathy might go away. But the truth is there's a lot of Americans that don't have neuropathy and have impaired glucose tolerance. So you're not really doing that much. When you get off of the question of the phenotype, the other big hint that you might be dealing with a treatable neuropathy is when they have these findings on their nerve conduction studies of conduction block where you can't get a signal through when you stimulate proximally, or temporal dispersion over here where you get a fuzzy signal that gets through. The nerves are all conducting at different velocities and you get dispersion of the waveform. That finding itself is a big hint that you might be dealing with a treatable neuropathy. But the truth of the matter is we don't see it all that often. So what do you do when you get a patient with neuropathy? Usually with numb feet. You will order a bunch of tests. I could probably give you a separate lecture that these tests are not going to lead you very far. I mean, if I just take the first one up there, if I want to say something somewhat controversial, if you prove somebody has B12 deficiency who's got numb feet, you may have not found the cause of the neuropathy anyway, because B12 deficiency technically probably causes a myelopathy, not a neuropathy. So, you know, and a lot of people probably are walking around there in the normal population with low B12. So, again, what did you really find? But the truth of the matter is you're going to think about it. You're going to run a lot of tests. We'll go a lot faster now. So anyway, so if I jump down to the bottom of this, list of workup for neuropathy patients, you get into this test called the serum protein electrophoresis, or SPEP, or an IFE. I think a lot of people would argue that that's probably the most informative test you're going to get when you're working up a patient with numb feet. And again, I'm going to try to just be simple for a second. What you're looking for in that test is an abnormal population, in a neuropathy patient, is an abnormal monoclonal population of antibodies. The antibodies could either be IgG, IgA, or IgM. And they all have different meanings. So a lot of the times what you'll see people saying is the patient had a positive serum protein electrophoresis. My pet peeve is you'll say to them, what was the category of antibody? And frequently they can't answer the question, heavy chain or light chain. It actually matters, not that the test is quote-unquote positive. But once you figure out what the antibody type is, you begin to think about it. This is just a picture of what the test looks like. So you do an electrophoresis of your serum proteins. And in the normal case, in the gamma globulin fraction all the way here to the right, you don't get a spike. In cases that have a monoclonal protein, you'll get this big monoclonal spike of protein all phoresing to the same place. There's another test you could do called an immunofixation electrophoresis, which is more sensitive. For the purpose of this talk, this is really all you'll have to know. So you're looking for this thing called a monoclonal protein. So if you find a monoclonal protein, what you're generally indicating is there's an abnormal population of plasma cells somewhere in this person's body. What that clone of plasma cells could be in your bone marrow, could be in your blood, could be in a lymph node. Usually it's in the bone marrow, and you're now trying to figure out the significance. And I think just as a simple way to think about this, a very simplistic way, the clone of plasma cells could be benign, like a benign tumor. It's not growing, but it's there, and it's producing this clone of plasma cells. And the plasma cells are making antibodies. Or it's malignant. It's growing. It's crowding out cells. That's what multiple myeloma is. And I think in another sense, for simplistically, the M protein that you have, the monoclonal protein could be doing nothing. You just have a monoclonal protein in your blood. It's a bunch of antibodies. They're not really doing anything. Or the antibodies could be attacking your nerve, which is something that we're interested in. Or the antibodies could be so abundant that they're causing a clinical syndrome like Waldenstrom's, where your blood is too viscous. Or they could be causing amyloid if it's light chains, for instance. So this is just a way to think about this in general. Now, when you start thinking about neuropathy, like I said earlier, you have to break down these antibodies. You could have IgM antibodies, and IgM antibodies tend to go along with the disease I'm going to be talking a lot about in the next half hour, which is this disease which we call DADS, distal acquired demyelinating symmetric neuropathy. The monoclonal protein in this case has a reaction against myelin-associated glycoprotein, or MAG. So it's really, just remember that first bullet and you'll do okay for the rest of the talk. Now, IgM could show up in cases that have CIDP. It could show up in vasculitis cases. It could show up in amyloid cases. It could also show up in monoclonal gammopathy of uncertain significance. In other words, there's a paraprotein there. We don't know what it's doing. and then on for IgA and for IgG and IgA. But pay attention right now just to the first bullet. Now, just this is a bit of logic, which is worth spending a second thinking about. You have two findings in the same patient, okay? I think we always have a tendency to jump towards causation whenever we see two findings in the same patient. In this case, you have a neuropathy. Your patients come in with numb feet, and you have a paraprotein in the blood, all right? Maybe it's IgG, maybe it's IgM in this case. Spend a moment to think to yourself what these two findings could be doing in the body. They could be unrelated to each other, okay? When they're unrelated, the neuropathy and the paraprotein, that's what we call monoclonal gammopathy of uncertain significance. 5% of the normal population after a certain age, older people when they're in their 70s, have a monoclonal gammopathy in their blood. A certain percentage of that population also has neuropathy. Obviously, the two things could occur coincidentally. That's what we call monoclonal gammopathy of uncertain significance. Second possibility you have to think of, which is often the case when you have an IgM paraprotein, is that the paraprotein is the cause of the neuropathy. It's either binding the nerve or doing something funny to the nerve. That's what we call DADS, this distal acquired demyelinating symmetric neuropathy. Amyloid, where light chains are getting into everything, would also be an example of the paraprotein causing the neuropathy. The other possibility is thing B causes thing A instead of thing A causes thing B, so the neuropathy could cause the paraprotein. I personally can't think of any example where that would be true. And then there's the last possibility that another phenomenon is causing both. So here you might have an abnormal clone of plasma cells or lymph cells that's making a bunch of cytokines, and that's causing one type of disease, and it's making a bunch of antibodies, and that's causing another type of disease. So that would be a third thing causes both. But in this case, we're going to be talking about cases where the paraprotein causes the neuropathy. So that's just the background, and now we'll kind of move in the next half hour into the basics of the talk. So this is just where the world's going and how we're going to learn about information and how we're going to resolve conflicts in medicine. In the old days, here's a picture of Charcot talking to a bunch of really famous neurologists in Paris, probably in the late 1800s. And it's the concept of the lecturer says something and everybody believes it, and that's the way that medicine is. Nowadays, we have people all over the country in different places, different countries, and everybody can get together and talk. So now we do things differently, which is we get on the internet and we talk to each other and people can learn. So there's a website now called Rick's Real Neuromuscular Friends, which has been a really active, excellent forum for people discussing kind of high-level neuromuscular cases. We kind of think that it would be a really great thing to adapt into other fields of neurology and even other areas that aren't part of neurology. But for the most part, it's been a really interesting thing. And this paraprotein disease is something that's been incredibly interesting on the website in the variability of how people practice. So this is what gets into the concept of non-evidence-based medicine. But again, the most common IgM neuropathy is this disease called distal acquired demyelinating symmetric neuropathy. It tends to occur in older age patients. It's an IgM paraprotein. Most of the patients who get it are men. The light chain is almost always a kappa light chain, probably 75–80% of patients. When you do their nerve conduction studies, I won't go into it, but they have a very specific type of slowing where the nerve conduction slowing is greater in the distal segments of nerve than the proximal segments of nerve. It's very uniform. You see more or less the same thing in all of your limbs. Axons also get destroyed in this disease. It's not pure demyelinating syndrome. So even if you can put the myelin back on the nerves, there's this issue that maybe the axons are destroyed and the disease isn't going to get better anyway. It responds very poorly to therapies in general. I think everybody would agree with that, although how poorly gets to be a big question. The other thing is the long-term course of this disease probably, for the most part, is fairly benign. So if you take these patients from the time it starts out a decade, they're probably not getting a ton worse. So what you really have here is older people with a relatively indolent chronic neuropathy who probably don't respond that well to therapy. And then they have autoantibodies to myelin-associated glycoprotein That's a protein that more or less has something to do with the wrapping of myelin around the nerve. So you begin to interfere with that, and you may have problems with the way myelin wraps around the nerve. So the picture I've put up here is kind of this concept of the I can never say the word, but the wrappings of the myelin beginning to kind of unravel a little bit. So they widen, and you get these widened myelin around the nerve. That has something to do with the pathology. Axons dying probably has something to do with the pathology also. So this is just another depiction of the disease. So when you're looking at a patient clinically, you're kind of taking just an overview approach to a patient without thinking about pathology. How would you know this disease is present? First, they'd come to your office. They'd say their feet are numb. Again, usually an older man. You'd either do your nerve conduction study or do your blood work first, and you'd find an IgM paraprotein in the blood. You might do your nerve conduction second, and you find this uniform pattern of slowing. You put this triangle together. This is one of the occasions where then you might go and order an antibody test against MAG, and in about 70 or 80% of cases, the MAG will come back positive in this disease. And you've put it together, and this is the diagnosis of DADS-M. And now we're going to be talking about this very specific syndrome. I've recognized it. I'm sitting with the patient. What do I tell the patient to do? Now, here's the way this might look on a website that's being shared by a lot of neurologists. And I use myself to start the first thing. So, is anyone actually treating this? I don't think it makes sense. Relatively benign disease versus long-term treatment with questionable response. Weighs in favor of staying back. So my thinking in this case, sometime maybe 10 years ago, and I'll show you the paper in a minute, but Rick and I wrote a paper about our first experience with these cases. And it was before the era of rituximab, which is kind of the hot treatment for this disease right now. It was in the days where we were using prednisone, IVIG, plasmapheresis, Cytoxan, whatever you can think of that's the immunological agent that you want to use on a patient. And what we noticed is that when we were treating these patients, we would look back at their treatment, and they've been on 10 different therapies. But when we had our patients with the classic CIDP, that first slide that I showed you, the very first slide, those patients had been on one therapy, maybe two therapies, if they had side effects on the first. When you see that sort of pattern, it's indicating nobody was that happy with the first therapy, so you switch to a second therapy, and then you switch to a third therapy, and then you switch to a fourth therapy, because they weren't responding. So we started to say it's important not to just call this condition, it's just important not to call this condition CIDP and just lump them into a category of demyelinating neuropathy. So we invented the term DADS, so people would split this off and think about it differently and maybe talk to patients differently. Before we wrote this paper, a lot of people would refer to this condition as CIDP just because they were slowing and neuropathy together. So what do we get when you throw this question out into the group? There's a group that just screams out, no, we've been unimpressed, we've given up, we're not going to do this anymore. And then there's a strong group that says, yeah, we treat these patients. Probably a bigger group says we treat these patients. And when you look at those posts and say what they say, they're interestingly all basically saying the same thing. Not indolent. One of the posters says not indolent with distal motor involvement. So kind of the point is, I wouldn't treat somebody with a very slow chronic disease where it's very mild, but if it looks like it's going fast and they're picking off their nerves really quickly and they're getting weak in their ankles, I would treat these patients really aggressively with rituximab. Somebody else says recent onset with severe or mild involvement, without severe or mild involvement, with the concept that if it's severe, their axons are wiped out, and if it's mild, why treat them because it's such an indolent disease. So it's the intermediate cases of recent onset. So I think it's more or less saying the same thing. Somebody else says early before they come wheelchair bound. So again, I think that's that same concept. And then these people are reporting 50% responses of their patients to rituximab. I can tell you from personal experience, I'm not seeing this. Everybody I treat has not, I don't think I've seen anybody have a robust response to Rituxan. And I've probably treated 10 patients myself. So it gets very interesting. Why are people seeing things that are so different? What are the biases that are leading people to have completely different interpretations of the literature? And I think this gets towards the concept of non-evidence-based medicine. I wouldn't just look at the question of the literature. What does it say? Because we're probably, I mean, we're going to look at the literature in the next few slides, but I wouldn't necessarily just look at this question as the literature doesn't say anything. I think when you're talking about non-evidence-based medicine, you probably want to explore a little bit of how doctors are making decisions when the evidence is somewhat imperfect. So just some of the things to think about. It's a relatively benign disease. And this, I think any medical student could ask yourself the question without knowing one thing about the question. You could go for any disease. You have a relatively benign disease without much progression versus using a long-term, strong immunotherapy and getting at most partial improvement. And by the way, the therapies aren't cheap, and you probably have to stay on them for a really long time because you're not going to cure the disease with the therapy. So I think most people in this case, and you could probably pose the question 100 different ways to get people to think differently about how they would answer the question. But most people in the disease would not agree. Most people looking at this, you're not going to get 100% say treat it. A lot of people are going to take a paternalistic approach to the patient. You're going to do this. A lot of people are going to let the patient choose. So you're going to get very different responses. Other influences are, what was the last case that you saw? If the last case you saw had a great response to therapy, you're going to remember that case. You're going to treat more patients. People are going to look at the literature and interpret it differently. And then there's the question of what constitutes improvement. If the numbness goes from your knees down to your mid-calves, is that worth it? If the numbness goes away, is that worth it? If your ankles are a little weak and they get strong, is that worth it? So how does one person see 50% of patients improve and another person says, I don't think this therapy is worth it? So what does the literature actually say? There's really only 2 papers that give you any information about this. One came from Dr. Marinos Dalakis when he was at the NIH. Did a placebo-controlled trial of rituximab. Basically, you give the therapy. Therapy takes about a month to give, and you see how the patient does a year later, because rituximab will wipe out your plasma cells, so you don't make antibodies for a long time. The antibody titers will drop, but maybe the nerve doesn't get better because there's axonal damage. Maybe the nerve does get better. He uses something called an INCAT score, and for the sake of simplicity, this is just a score that you score 0 if the patient's fine, and you use a Likert scale and score 5 if the patient's restricted to a wheelchair. Usually the patients with magneuropathy are going to be who are going to be in a clinical trial are going to be in the 0 range. Many of them are going to walk fine. But when you do a clinical trial, you're going to want the 1s and the 2s. You're not going to see a lot of 3, 4s, or 5s with this disease. So when he does the treatment study, he finds, if you just look at A, that the average score at the beginning of the trial is about 1.5 for the placebo group and the control group, about 13 patients in each group. And the average score at the end of the study is down to 1 in one group and 1.5 in the other. And if you look at his numbers in the bottom corner, he's saying really that in the treatment group, about half the patients got better, and in the placebo group, really nobody got better. So he's seeing the same thing that these other doctors are seeing. Now, these scores in a study are averages, but there are some individual patients in there that might get better, and I think that's what people's experience is. So I think a lot of people conclude that it's worth trying a therapy in these patients. So he said the improvement was studied with high titers and more severe sensory impairments, not associated with a few other things like disease duration, age, IgM level, electrophysiology, axonal loss. Doesn't entirely mimic what the people are saying on the website, but you can see how a study like that would match onto somebody's experience. There's another study out of France that came out this year, and I put the table up on the right, and I just want to point out one thing. If you go back to the beginning of what I was saying, if you take patients with IgM in their blood and you don't take another step to think about it, nobody is telling us in this study that all of these patients have DADs. They're not using a clinical representation to break down the cases. They're using They're not using a phenotypic representation. They're just basically saying, let's take patients with neuropathy who have IgM in their blood. So some of those patients in these studies could potentially have CIDP. CIDP responds to therapy pretty much all the time. So are you going to trust these studies 100% without a phenotypic explanation of what's going on? It's an open question. So this study had about 54 patients in it, and they used an endpoint which is sensory scales. So they tried to figure out if the patient's numbness has gotten better. And if you just look at the right, as a group with these patients, the p-values are all around 1. They didn't see anything. But when they went to patients' subjective sense of improvement, when they went to things like the INCAT scale, once again, you found the same pattern. About 50% of the patients improved, and about 50% didn't improve, and the placebo group didn't do well. So interestingly, the same study. Cochrane, which is our evidence-based anchor of medicine. Everybody knows what the Cochrane, I hope everybody knows what the Cochrane reviews are. But they'll look at the literature really close and ask the question, is there strong evidence that these patients respond to therapy? These studies, remember, weren't very big. Cochrane doesn't look at individual responses to therapy. They're looking at group responses to therapy. It's a small study, obviously not a very robust response. And Cochrane says there's no evidence. But is something in the evidence-based medicine world going to influence doctors who may see improvements in a few patients? It's just important to think about that difference between evidence-based medicine and non-evidence-based medicine and understanding what goes on with something like a Cochrane review. But they vote no. They would have put up in our NMF, no, you shouldn't treat these patients because we don't have evidence that's beyond a reasonable doubt that the patients respond to therapy. So then the question gets to be, maybe the reason that people are responding differently on the website is because it's a matter of phenotypes. And I stuck one of the presentations up here to prove the point from a doctor who gets clearly that CIDP phenotype might matter. So he writes CIDP phenotype with anti-MAG IgM. Patient responded to therapy really well. So CIDP cases can have IgM paraproteins and are likely to respond to therapies. So again, here's just more responses to that post where people are saying, all right, maybe if it's a proximal phenotype, but if we go back to the literature, never was clarified, so it makes it difficult. And when you start getting into the deeper dive, when you start getting into what people are saying on the website about patients that they've seen respond who have IgM and neuropathy, a little of it starts coming out. Maybe there's a lot of proximal weakness. Maybe they have that CIDP phenotype, and that's why you're seeing some of these responders. And here's an example from one of my friends. I took the names out just because I didn't want people to because we don't have permission or whatever. But here's a case that clearly has a CIDP phenotype. The deltoids are weak, biceps weak, triceps weak, hip flexors weak. It's generalized weakness. Not surprising a patient would respond with this to immunotherapy, but it's very easy to say I have an IgM MAG neuropathy case that responded to therapy, but it's not DADS. And the question is really about DADS responding to therapy. This is the paper Barron and I wrote 10 years ago that gets into this distal neuropathy. And like I was saying earlier, if you take the patient with DADS and a monoclonal protein, you could see that they were on a lot of therapies. So this is 10 cases, and they'd been on prednisone, plasmapheresis, immunoglobulin, and Cytoxan. And the CIDP cases, 21 patients, they'd had a total of 25 therapies. Here, 10 patients had a total of 25 therapies. So that's just kind of what you're going to see if you treat these patients. It's interesting to think a little bit about you're in an era where you had not yet defined the disease DADS, and you were thinking of it as CIDP, and you were throwing a lot of therapies at the patient, and they weren't responding to therapy, so you'd go to the next therapy. But now we have a totally different mindset about the exact same topic where patients have this distal IgM neuropathy, and it's just a question of, does this drug work? I think this drug works. I don't think this drug works. As opposed to lumping those patients into a category of CIDP which should respond to therapy and being constantly disappointed because you're never seeing a good response. So again, there's something about the way doctors look at these cases that influence their interpretations about whether patients are responding to therapy and whether they should continue therapy and be treated. So a little bit more on phenotypes with this topic. So here's a very interesting post. It's a very interesting twist, but I saw a 51-year-old woman with a subacute asymmetric onset bilateral foot paresthesia and a small IgM monoclonal protein. So now you're talking about a brand new phenotype. It's not CIDP. It's clearly not a boring, length-dependent, symmetric numb feet case. And she wants to know, what would you do? What would you test further? And this stuff is actually all in the literature. If you look deeply at it, people are talking about it. So some people say, yes, I tried therapy on that patient, including Dr. Barron. Some people say, no, there's not enough there. I don't know what you're talking about. I certainly wouldn't agree. We get 100% agreement from Dr. Shabani, and we get 100% disagreement from others. So it's interesting. Then you have another doctor, if you read the paragraphs quickly, saying that he agrees and disagrees. So tough topic. But when you look deeply at this, there are papers on patients with IgM paraproteins and asymmetric neuropathy who have very distinct pathology where the IgM molecules themselves are getting intercalated into their myelin. And they present with this unusual disorder. In a sense, it's amyloid-like, or it's an aggregation of protein and nerves, and it presents with this very asymmetric pattern. So it's been caught by some doctors. Does this disease respond to therapy? I think, again, you'd have to think of it individually to really ask the question. Then you get into the question of IgM mugus neuropathy. I have a patient with IgM mugus who has a progressive axonal neuropathy. So again, phenotypes. Now you have a different thing. Numb feet, but the nerve conductions aren't demyelinating. What's the IgM doing there? So it's possible that now you're into the category of actually finding a patient who has two findings together that are unrelated to each other. We have no proof that they're related. Is this patient going to respond to therapy? Do you treat them just because they have an IgM? Or do you have to split it out and think about it differently? I think it's the last category. So I won't read that slide because we're short on time. But finally, I'm just going to sum up. There's been a paper that came out recently from Dr. Lugeti. And I think this is a really good summary of the topic that came out quickly. And I think it begins to orient us about how to think about the topic. And he used the term atypical IgM and MAG. So it's finally at least popping out in the literature to think about these cases in completely separate categories and try to break them down into individual whole syndromes that are phenotypically, pathologically, and electrodiagnostically based. It's a really hard thing to do when you're doing clinical trials, to get so definitive about your cases that you're going to limit your criteria for inclusion in the trial. Because it gets harder and harder the more criteria you take. But the more criteria you put, the fewer criteria you put into the trial, the more heterogeneous your population gets, and you depower your study, and it gets harder and harder to draw conclusions. So this paper I found very important. I'll just go over it in 2 minutes. But they broke it down into a classic phenotype, which is the disease DADS, basically, which is the majority of these patients, although it's not a supermajority. You'll see what the numbers are like in a second. And then what they called an atypical phenotype, which a great way to think of it is anything that's not DADS. And then you're going to take the atypical phenotype and ask, what are those diseases? And you're going to take the DADS phenotype. And when you look at their cases, the classic phenotype goes from 14 to 31, so it's about 18 cases. And the atypical phenotype, about 13 cases. Let's go back into a study that hadn't necessarily broken down the clinical phenotypes. Let's go back to the beginning in our minds for a second. And we find out that that study is going to have roughly 40% of their patients are going to have an atypical phenotype, and roughly 60% of their cases are going to have a typical phenotype. Perhaps the typical phenotype, perhaps, is going to have a harder time responding to therapy. The atypical phenotype, an easier type, responding, easier chance. And here's what they end up finding out. They came up with 3 atypical phenotypes. They came up with multiple mononeuropathy who have IgM and MAG. I think their concept in these cases is that they had they actually had antibodies of IgM and they had vasculitis. Not surprisingly, vasculitis cases with mononeuritis multiplex respond to prednisone, they respond to immunotherapy. They came up with a symmetric polyneuropathy with predominantly motor impairment. That sounds very CIDP-ish to me. Not surprisingly, they're going to respond to therapy. And they came up with a painful shooting neuropathy, which was the one case of their atypicals that responded poorly to therapy. So when you think of that painful neuropathy and you go back to the first slides I was talking about, that's your length-dependent neuropathy. Those cases usually don't respond to therapy. That might be your muggus as far as this paraprotein is concerned, like that earlier post showed. So here's their punchline. The atypical cases respond to steroids, except pretty much case 12, which was the painful neuropathy case. So here's some conclusions, and then the classic cases don't respond to therapy very well. So here's some conclusions about IgM neuropathy. We should stop classifying the disease as IgM neuropathy without a qualifier. There needs to be a phenotypic qualifier. There needs to be an electrodiagnostic qualifier. We were probably right to use the term DADS and split it off with everything in the first place. The difference in response observations may be from distinct clinical presentations. It speaks for itself. Caution grouping cases into a single antibody syndrome. And different phenotypes are probably and may not be the same disease. So frank IgM deposition in the asymmetric neuropathy cases, that's what the Mayo Clinic reported. There's probably some amyloid in these diseases where the small chains are getting into the nerves. There's probably vasculitis, and in this case, the M protein and vasculitis are probably both brought on by a third factor. Maybe the plasma cells are influencing the immune system. You have vasculitis, inflammation, response to steroids, and you happen to have a monoclonal antibody. And finally, the classic condition, like the paper I just showed you showed with the triangle, the DADS phenotype, we still have a jury that's out. And you know, if you guys want to ask questions, I'm going to stop now, but if you guys want to ask questions, I think it opens up to questions in your own fields. Why do people see things differently? What sort of techniques can we apply to the field that will help us discuss things that people are seeing that are different? I think a lot of these things are probably going to come down to further discussion, listening to each other, finding ways to open up for what are the differences in the different cases. I think those techniques still need to be developed, and I think the communication of experts on the web might be an important first step. So thanks.
I'm trying to understand the history of how DADS got defined. Is it that it was originally kind of lumped in with CIDP, and then it was associated with, then it was CIDP that had an IgM, and then it was a CIDP with an IgM that was anti-MAG?
I think that's along the right lines. I think, you know, at one point there was these two diseases floating around. And Rick might have more historical perspective than me, but you had IgM neuropathy, you had Muggus neuropathy. If you look at the original CIDP criteria, they weren't breaking it down into IgM versus IgG versus IgA. It was just neuropathy with the paraprotein. Then I think people, from one angle, got more focused on these IgM cases, that they're fairly common. You see them all the time. They're older men. So people started seeing that angle. But at the same time, in other schools of thought, maybe if you're in practice and you're not going to a lot of grand rounds or not thinking a lot about this, you have people that have clear demyelination on their nerve conduction studies. And even in that group, you have some groups that have conduction blocks and temporal dispersion, like that one slide I showed you, and some patients that have this uniform slowing with distal involvement. People started going, are those the same thing? And I think what we were trying to point out in this paper, and it sounds like it's nothing going back 15 years, but we were really pointing out something, is there's this uniform syndrome in the middle that has the uniform slowing, the numb feet, and the IgM paraprotein. And if you look at that group as its own distinct entity, we've been having a lot of trouble treating them. the DADS was just like a warning sign that says don't lump all these cases together because it's so easy to just say it's a neuropathy with conduction slowing. That's CIDP. Let's not think about it further. Or it's a neuropathy with an IgM paraprotein. Let's make that the category. The argument is you got to narrow your categories down into these very specific syndromes. And I think that's what a lot of people are starting to see in the literature. And that was what was bubbling up in those papers into even more syndromes.
So DADS doesn't equal anti-MAG.
DADS, for our purposes, was just the outside triangle. And the MAG part in that is we're saying that if you test the MAG antibodies once you've diagnosed DADS, I used to have the slide so the MAG thing would flow in from the side, and it would say 75 to 80% of those patients are going to have MAG antibodies. Problem with MAG antibodies is in some of those other phenotypes, they also have MAG antibodies. So there's a question, does an IgM paraprotein have some binding to MAG that's nonspecific in some cases? Now, instead of getting into the clinical empirical reality of the whole thing, when you start getting into the pathology, we end up getting even more lost. We don't really know the answers to the questions. But there's MAG reactivity in different phenotypes.
That is a pretty deep dive. So, but on the big picture, you said you used one of your alternate titles is non-evidence-based. And actually, I don't think it is. I think it's what is the threshold for evidence that we use to make our decisions. So when we see patients in the clinic and we try something and it works or it doesn't work, that's evidence. But the evidence that the Cochrane uses and that Gary Grance's practice parameter uses is a whole different bar. And so where's the truth in that? Where do you cross the threshold that the evidence is? And now we're moving to this whole world of Patient Centers for Outcome Research Institute grants. We're going to be collecting evidence real time in the clinic through our EMR, and that's going to be a whole different type of evidence than what Gronseth and Cochrane are used to using. And that's going to be evidence that we're going to be building to help us make decisions for the future. So I think that's really, at a big picture level, what you're talking about. What is evidence?
I think we're saying the same thing. I mean, what a lot of the current push towards evidence is we want to give things high categories of evidence so we can believe them. And insurance companies want to look at that and say, you don't have a high category of evidence, you can't use the drug. But when you have something that's at a low category of evidence, like completely uncertain evidence, I think we want to think about what Dr. Barron just said, which is, well, we have evidence out there. It might be uncertain, but what tools can we use to actually figure out what to do? What are actually create rules around uncertain evidence that help us make decisions? Yes?
You're sort of saying it's relatively easy to evaluate objective quantitative data which you get from your tests. But as a non-physician, you guys do a lot of having a feel and a sense of what's going on with the patient. And you just, from years of experience, you get patterns evolve in your head.
Patterns, yeah.
It's patterns.
So does the
that's
patterns we
qualitative,
get from our physical exam and
level
history,
of analysis and input. And
Right.
if you're going to try and sell that to an insurance company, that's probably a lot more
tougher
challenging.
sell, isn't
It's
it?
a different sell.
I also think there's, the psychologists of the world, or the social psychologists, or the anthropologists. It'd be interesting to see them get involved in the field a little to look at evidence, not from the evidence itself and what does it say, but to look at the psychology of the doctors and the patients and what those forces are in clinical decision making. Because I think if you could reflect that back to people in some kind of objective sense, it would get to the core of what these questions are and why do two people see the same thing and react completely different to what the right choice is? There's a lot of subjectivity in those decisions, and the subjectivity comes from a lot of past experience of people.
There's lots of evidence that the Earth is flat. If you look outside, it looks flat. It's not evidence.
Yeah,
I mean, that's either scientifically proven evidence or it's just subjective.
I'm pretty sure the Earth's flat.
well, maybe that's the conclusion of the talk. The Earth is flat. All right, thank you very much.